Good morning and welcome to yet another MCQ recall for this NEET August session. I believe an image of Graves' disease or eye signs in Graves' disease was shown, and it was not just asked as a spotter. What is this? Is this Graves' disease or make your diagnosis? Nothing like that. In a very indirect way, they try to find out whether you can dig into your conceptual way of thinking. So nowadays, no more images are just asked for diagnosis. They are asked for you to go deeper into your physiology, pathology, and allied subjects and come out with the right option. So the answers, the options were: eye manifestations improve with thyroid status improvement. The eye disease can occur in a hypothyroid state. It's an autoimmune cascade, and TSH receptors are maximum in the fibroblasts. Now, the options for it to be ad verbatim as given in the NEET August PG can never ever match, because for every question or for every MCQ, instead of 4 options, we managed to get 8 options. So we try to put them as close as possible so that you will be able to tease them deeper. And as usual, the images are from my personal collection and patients have consented. These photographs or pictures are to be strictly used for educational purposes. Now, what is the basis of a thyroid eye disease? It's a chronic immune-mediated inflammation of the orbit itself. There are a lot of structures inside the orbit. If you understand that this inflammatory cascade is going to hit on almost all cells inside the orbit, you will be able to appreciate why these signs are there and how these problems can be tackled. So the etiology of thyroid disease is eye disease is not well understood. You just know it's an immune-mediated cycle involving the orbital fibroblasts, adipocytes, and lymphocytes. Now the target cells are the fibroblasts because they have a lot of TSH receptors, and these are the ones that can also differentiate into mature adipocytes. So the clinical presentation, as I told you, always the clinical presentation of anything or the seriousness of an issue will be always following a spectrum. If you know where exactly in the part that the patient is in the spectrum, you will know what treatment to give. So it can be just a unilateral dry eye disease. Now, never think somebody is going to sit in the green and come to you. They'll be at home. If they are coming to you, they are probably sitting in the greenish to yellow and starting off. Now, unilateral dry eye disease. It can go up to sight-threatening complications also. So any thyroid case that comes to you, look for covert eye signs. Don't wait for them to show ophthalmos or severe keratitis for you to offer an ophthalmoplegia for you to diagnose eye disease. So catch them here itself. Any thyroid, look into the eye signs, not the gross eye signs. Gross eye signs you can pick up easily, but look for the subtle eye signs which will be coming down the list later. So now these are the various eye signs. You see proptosis. This has been given to me by our endocrinologist, Dr. Vasanthi. Absence of wrinkling. They are able to see up, but no need to wrinkle. It's not that the muscle is paralyzed. It need not be used to look up. It's as simple as that. Or they can have a staring look. We are just putting it very simply. Now, 50% of Graves' disease, they present with the thyroid eye disease. This you must keep in mind. Somebody, let alone Graves' disease, somebody features of hyperthyroidism or Subclinical hyperthyroidism, which has been picked up on your thyroid function test, look into the eyes. Thyroid eye disease can also occur in the hypothyroid state. You see, somebody treated with Graves went into the hypothyroid stage. Don't forget to look into the eyes. Or somebody with thyroiditis. Initially, there will be thyrotoxicosis. When they come to you, they may be hypothyroid by then. After a few weeks, still look into the eyes. So the dictum is, any thyroid case, please look into the eyes irrespective of the function. Now, as I told you, this is the diagram of the orbit. I've purposely stretched it so that I'm able to fit the various problems in the anatomical places. So you know, eyelids, ocular surface, orbital, extraorbital muscles, and the optic nerve. Now, what are the problems? The fibroblasts sitting here are the problem. They can also differentiate off into mature fat cells. These fibroblasts have lot of TSH receptors. That is why they are proliferating because of thyrotoxicosis. So, as I told you, it is not well understood. Orbital adipose tissue is a unique fat depot because it responds to TSH. Of course, it has come up from fibroblasts, but on its own, it also responds to TSH. No other fat will respond to TSH. Robust orbital inflammation produces high levels of pro-inflammatory cytokines. We are not going to go into the inflammatory cascade. Now, what are the target cells? It is the fibroblasts. So, among the three, the target cells are the fibroblasts. They have increased expression and they also have tumor, they have growth factors. I'm not reading them individually. So what is the risk? Not every thyroid toxic patient or every Graves patient will have eye problems. One is ethnicity. That as far as Indian population is concerned, we did not find any studies, but in the West it is the Afro-American population. Age, there is a bimodal peak incidence, 40 to 44 and 60 to 64 in females and a decade later in males. Gender, there is a female preponderance because females as such have a higher incidence of autoimmune diseases. And males, when they have eye problems, they present much more with severe issues. Genetics, autoimmune disorders, associated autoimmune disorders. Somebody is having SLE, somebody is having polyarthritis nodosa. They are more likely to develop eye problems in thyroid. Smoking, dysthyroid status. 90% at the time of eye signs will be hyperthyroid, and up to 3% can have Hashimoto's thyroiditis, and even 1% can be hypothyroid. They have high problems due to thyroid, but their thyroid function tests are hypothyroid. When you give radioactive iodine therapy, this is one of the side effects you need to explain to the patient and take prophylactic measures also. Stress, pregnancy, and trauma. Major trauma. Thyroid eye disease most of the time is self-limiting, so it's very reassuring. You have three phases. The initial phase is a steep rise in disease severity, going up to 6 months to 5 years. It's called the inflammatory phase. Active phase, and there is an inactive phase. The stable or inactive phase, the disease stabilizes and regresses subsequently beyond 18 months of activity. So when patient is asking for prognosis, you will know the time pathway of this disease and you will be able to explain. However, the disease never returns to baseline. The process never returns to baseline. The fibroblasts which have enlarged will remain enlarged. The adipocytes which have enlarged will remain enlarged. They cannot shrink back to normal size. Aggressive immunosuppression management will help in the initial phase and they can limit this destruction. So it is called the cone mode, where the muscles are enlarged, first transverse, then longitudinal, and cause all these issues. So let's have a look again. Let's look at the eyelids first. Enlargement and fibrosis of the levator muscle. Then there is increased sympathetic stimulation of the Muller's muscle. This is because of THS receptors there, and this is because of the sympathetic exacerbation. Then in the surface, there is in the interface itself, there is a problem. Patients can have dry eye and subsequently corneal problems. Then after that, the extraocular muscles and the fat will undergo hypertrophy. Now, it's not only hypertrophy here. What will happen? They will press on other structures. Ophthalmic vein can be suppressed, can be compressed, or the whole area here may be so enlarged that it will break the orbital walls. Your orbital walls are quite thin parts of the skull. They can easily break because the pressures are quite high here. The most common muscle involved is the inferior rectus. And you can have strabismus and diplopia. Actually, inferior rectus will produce diplopia. Now, what happens to the optic nerve? You're getting more and more into the serious issue now. Previously, lid cannot close, then you had problems with the surface, then you had problems with the muscles. Now, finally, you have landed up with the nerve itself. Now, the nerve can get compressed to the fat. The nerve can get compressed because there is venous congestion. There is less arterial supply because of raised tissue pressures here. And that is why, and not only that, it will also stretch the nerve. So you see so many things are acting on the nerve. So eyelid retraction is the most common clinical sign presenting in up to 74% of eye disease. Look at the eyelid retraction. It is because of enlargement and fibrosis of the levator and eye muscle. So it has pulled up the lid. Not only that, this part of the levator palpebrae is called the Muller's muscle. It is supplied mainly by the sympathetic supply. So it is sort of a aggravation. The main muscle is in spasm. The smaller twig, which is the Muller's muscle, through another attack, that is a sympathetic overdrive, that also will contract. So in the end, you have an upper eyelid retraction. You can have lower eyelid retraction also. What about medial rectus? As usual, the second one will be the medial rectus. There will be lack of convergence. You can see they are asked to see the point, and you can see that the eyes, they are really far apart. They have not come close together. There is no convergence to focus on this object. So it's the medial rectus which is involved. So coming to the question as such, patients with eye disease and Graves' disease, the following are true except eye manifestations improve with thyroid status involvement. We'll come to it. The eye disease can occur in a hypothyroid state. It is true, but your question is except, so it is false. It's an autoimmune cascade. It involves all the three tissues. So it is true, but your question is except. Thyroid receptors are maximum in the fibroblast. It is true, but again your question is except. The eye disease can occur in a hypothyroid state. I've already explained. So what is false here? Eye manifestations improve with thyroid status improvement. So this is false. It never improves. At least the pathology does not improve. Keep this in mind. Your symptomatology may improve, but your signs also may improve, but your pathology does not improve. That is why the earlier you pick up, the earlier you can give them the appropriate treatment. So this is a very short session. I just wanted to pick up the pathophysiology, connect it to a little bit of clinical findings and clinical medicine, and try to answer the options. Otherwise, it was not an exhaustive presentation on thyroid. Neither was it an exhaustive presentation on thyroid eye disease. It was targeted exactly at that MCQ. Along with that, I was able to squeeze in some of my clinical images and explain further to you. So thank you all very much. Please do subscribe to my YouTube channel and also my Telegram channel.